Right, we are now recording. Okay, so we're just going to get through a few real quick bits of business and then we're going to hand over to Andy Bond. All right, so first of all, we're going to do the usual business, the updates from previous meetings. Then we've got a progress checkpoint, and then we're going to get back into wave 2 decision making as we've done for the last couple of weeks. So I hope you've all got your trigger fingers ready to vote affirmative, negative, or abstain. I know how exciting that is. But first of all, we're going to just get through approving meeting minutes for 2 previous meetings. So the first one is the first one is the 20th of June. So this would have been shared via the list yesterday morning, running very slowly at my end. I apologize. Is that slow for anyone else?
Confluence is working fine for me.
Yep, it's just you.
Just me. All right. Okay, great. Well, we'll proceed then. So I'm going to put up a poll for approval of AU eRequesting TDG agenda and minutes. Could someone please?
Right. I'm happy to motion approval of that one.
I'll
Great.
second that.
Brilliant. Thanks, guys. Okie doke. So we've got 36 of 48. I'm going to close that. 3, 2, 1. Now. And that is approved. 23 affirmative, 14 abstained. All right, so the next one is the meeting minutes from the 25th of the 6th. That is working. Hooray. There it is. So there's the meeting notes from the 25th of the 6th. As per the other notes, they're mostly just the decisions that were made. So you can go back and review those if you're interested. Would anyone like to motion to approve those?
I'm happy to motion again.
I'm happy to second again.
Brilliant. So this is approving the minutes of the 25th of June. And closing that in 3, 2, 1. And that one is approved. 23 for, 14 abstained. Okie doke. So quick announcement for the next relevant event for this group, and that is the HL7 Australia Fire Connectathon and TDG meetings on the 20th to the 22nd of August. I'm happy to speak to these. Danielle, did you want to talk about them at all?
Yeah, that sounds good. I'm just going to drop some links into the chat to people. So it's register through Eventbrite. I've just popped one in, which is the Connectathon. So that's the 2 days, 21st, 22nd of March, which will be a testing event. Like it is if you've ever come to those before, and if not, absolutely please come along. Where we get together, we have discussions. We're trying to connect systems together, different sort of client servers, playing out those system roles with data. And on the 20th, we're looking to do a hybrid work group meeting day. So that'll be the 3 work groups that are currently running under HL7 Australia, which is the Fire Work Group, the AU Core Technical Design Group, and this group, the eRequesting group, will be in August. I realise it says 21 to 22 March Connectathon there. Thanks, Sanjeev. That's just obviously me not updating the slide properly. Promise it's 21st to 22nd of August. And yeah, thanks, Chris. And so all of those are held on the 20th of August day. I think there's also going to be an annual general meeting going on with HL7 there as well, where people can go, well, what does that even look like? And there'll be some afternoon events. The agenda is going to be updated on the page later, but get in, as always, there's limited spaces. And quite a few of the spaces are already taken up. Phil?
Sorry, you can finish your thought. I'll give you my question. You decide where you want to pick it in. For the work group meetings on the 20th, is there a virtual option at all?
Yes, that's the intention, is to do hybrid. So that there will be, a in-person facilitator. We will provide a link, and we are going through that process of confirming with the facilities that we'll be able to hook that up to the room so that you can attend virtually if you cannot be there in person, because this is in Brisbane, just to clarify. Both of these events are in Brisbane, but we definitely don't want to limit the work group setting to participation to just the people who are face to face, but love you to come along. I know I'll be there and all the other Brisbane peeps. Thanks.
Awesome. Thank you very much. All right. So the next section we're going to go to is the progress checkpoint with Andy. Andy, did you want me to continue presenting, or would you like to present from your screen?
No, you can keep going.
Okay, awesome. I'll hand over to you then.
Excellent. So we're continuing our wave 2 excitement and getting through some more aspects of ServiceRequest. And just to note the timing that we have, there's not a lot of time left until we get to that ballot for comment being published. Okay.
Andy, I can talk to this. It's just the changes we've been making as we go have been put into the CI build. So that's available for people to look at now, see if all the changes have gone in properly and the like. So yeah, the links there provide you to that CI build where, you can see where we're up to and provide any feedback if things haven't come through properly.
And that link is in chat in case you wanted to click on it and entertain yourself. Alrighty, next. So we have had some discussion around service request identifiers before, and just to kind of make sure everyone's on the same page, we're talking about the service request. So this is the specification of work, and for those of you who come from a version 2 world, you know there's some in the version 2 land, there's some identifiers that play in this space. But I think from our perspective, the two things we need to, I think, keep in mind is that there is the concept of a group identifier, which is in effect what you're going to see on the paper form and what will be the basis of a paper request or the order that gets generated for pathology or radiology. And then there is potential for, as in most of FI, there's potential for a set of other identifiers to be added into each of the service request single instances, and those identifiers can be used for various purposes. The thing to keep in mind, I think, is that there needs to be a real business purpose to the identifier use. And for all of the stuff we're doing at the moment, this is in particular an R1 kind of approach. So we're looking at a starting point. This is not to say that further refinement may occur later on as implementation experience provides more consistency around how these things are used in the real world. So the proposal is that for identifier, we allow for any number of identifiers to be provided with a service request, recalling that a set of service requests in, say, the pathology instance might be part of the group identified order that you take to your pathologist, for example. We have made it 0 to many, but if there is a identifier provided, then you should support it. If you do have an identifier, you should include it. That's why we've got 0 to many, and we're not being prescriptive on the type of identifier. You could use one of the AU local order identifier types profiles, or any identifier you want. So for instance, you could add a placer identifier in there. You could add anything else that you find is meaningful to include with that service request. Are there any questions? Excellent. I think we put it up for vote in terms of whether this is an appropriate starting point for us to move forward with the adoption of identifiers. So we definitely won't, with that 0 there, do not confuse it to say we are prohibiting the use of identifiers. We're absolutely supporting identifiers, and we are saying that you, if they are provided or you have one, you should put it in there because it could be useful. So Chris, do you want to put up the vote, or are we just going to do it by
Sorry,
show
was
of
that
hands?
you motioning, Andy?
Yes, I'm happy to motion.
I'll second that.
Thank you very much. All right, poll incoming. If you would like to motion to support this particular proposal, please tick the box. All right, we're at 78%. So I will close the voting in 3, 2, 1. All right, and that one is approved. 45 for, 4 abstained, none against. Thank you very much, everybody. That was
Champion,
nice.
slide 11.
Ooh.
Better close mine.
Sorry, before
No.
you proceed, can I just confirm that someone is taking notes today?
Yep, on it. Thanks,
Brilliant.
Chris.
Thank you very much. Cheers. Sorry, Andy, please continue.
It's a well-oiled machine. Next one, note. So this in FireSense is an annotation. We are allowing for many notes to be provided. These are clinical notes in effect, and the reason for allowing many rather than mandating you can only have as maximal as 1 is that there may be very good reasons why you want to ensure that there is an ability to separate out different notes for different purposes. There is no, at the moment, I think there's no need to constrain, and I think at this point in our evolution that where it is, unless there is a really strong reason to instigate some constraint, we should be as open and inclusive as we can moving forward. So any questions? Danielle.
Just wanted the proposal is that we don't further constrain this, basically. Yeah.
Yes. Unless
Okay.
you have a good reason to further constrain. And this is not the last chance you have to propose such a constraint. However, if there is something blindingly obvious you think we've missed in terms of how this is going to be used, then certainly feel free to speak up. Otherwise, we will look to move forward with the any constraints to come out within the experience of use that we may have over time.
All right. I'm happy to motion that proposal to not further constrain this.
I'll second.
Well, you're not, Danielle, can I just say that you're not just motioning not to constrain, you're actually motioning not to constrain and to adopt this approach.
Yes, and I thought that was the approach. Yes, I am.
Excellent.
Sweet. So the poll's up. So get voting. All right. So if you would like to vote, that service request note is adopted in the format you see on the screen. Please click the buttons. So we're at 82%. So I'm going to close the poll in 3, 2, 1. All right, so that one is 43 affirmative, 6 abstained, and it is passed. Thank you very much.
Okay, reason code next. Reason code is a codable concept. So just to go back and make sure everyone's on the codable concept page, that is the reason code can be provided as just some text, or it could be a set of codings or codes coming from appropriately defined code systems. We are proposing that there may be...
Sorry, yep, keep going.
That there may be multiple reason codes provided as codable concepts, and the proposal is that we recognize the NCTS reason for request value set as a preferred value set. That is to say, we encourage you to use these terms where they are applicable, but you're not required to do so if you have some alternatives that are more appropriate for your use.
And the NCTS reason for request is available from the National Clinical Terminology Service.
Philip.
Andy, just one quick question on this. And apologies, I've been away for a few weeks, so I'm sure it's obvious. But codable concept, does that still allow a free text entry if needed?
Yes, it does.
Okay.
You can either do free text only. You could do a one or more codings, or you can have both if that's what floats your boat.
Perfect. Thank you. Appreciate it.
Tawinda.
I was just looking at the file. There's no binding inside it. Do we need to put the binding there?
Yeah, that's the proposal, Talwinder, to bind to the reason for request with a binding strength of preferred.
Cool. So
Any more? Excellent.
Sorry, just to confirm again, will support text and binding if supplied?
Yes, you can do
Okay.
text only, you can do coding only, you can do text and coding. You can have many of them. We're
Yep.
pretty flexible.
You can do a different
it.
code.
You could use another code. You could use another value set if you want. I think, as we gain experience, we will, I think, come to some more cohesive agreement over time on the constraints we may, as a group, wish to place on this. But I think, like many things, we do need to not try to prejudge how implementation is going to kind of guide this going forward. So we start out with the minimum kind of constraints we need to move forward, and look to experience to guide us in future.
Thanks for answering my next question, Andy. Yeah, if you were going to constrain it in the future, but yeah, thanks.
Ken, was that a fleeting hand, or did I magically answer your question?
I'm not sure. No, I'm not sure what's happening with my hand, but this is a very interesting area because frankly, the MBS schedule doesn't have coding to allow for the reason for code to allow billing, and Medicare compliance is a major reason for all of this e-requesting activity. And I think that's years away before they start coding their reasons for requests. There exists reasons for requests, vitamin D, thyroid function. They all have reasons for, and they're all handed in free text form at the moment. But the plans for CDS in the future would be that those concepts would be coded and sort of allow for, well, force coding for things that are compulsory and so on. So I think that what you just said, Andy, was that we have to have it as free text at the moment, and it'll be up to the department and the HIC and everyone how they institute coding in the Medicare schedule.
Yeah, that's a good point. And I would say that before I get to you, David, that one of the useful ways of doing this in an existing implementation, if you have a user interface that does give some set of radio buttons or something for shortcuts to reasons, that you could bind them into a value set and at least present those as part of an approach, and that would allow you to kind of move forward with what you already have in place, and give more, I guess, specification rather than just resulting in those free text, but not then saying that in future, and I'm sure David's about to say this, that this would be one of the, I think, the areas where we would see some more investment in time and thinking around how we want to take this forward. David.
Yeah, I just want to back that up and back up Ken's comment. It's going to be a while, but it is something the Commonwealth are very interested in down the track. Hugely complex, lots of moving parts. But yes, I would say in future releases, we want to be looking at that.
Angus.
And I just add to Ken that it's very interesting because in future clinical decision support, when something suggests to you to do this test, that decision support will provide a code to say why it's suggesting to do this test, which they then drop in here, creating a sort of loop.
Brave new world. Any other questions? Excellent. Well, I'm happy to motion adoption of this approach. Is there a seconder?
I'll second Jamie Whale.
Thank you.
All right, everybody, you know the drill. Here's the poll. All right, everyone, that's great. I'm going to close the poll in 3, 2, 1. That one seems fairly non-controversial. 45 for, 1 abstained. The motion is passed. Thank you very much.
Oh, unlucky 13. It's like playing bingo. Encounter. So this is a reference to the encounter that was the basis for the request being created. We're proposing that it be a 0 to 1 cardinality, so it's optional basically. We are saying that you do need to have a reference to an encounter, which means you can't simply have it as being a relative reference to some kind of identified description. And considering using AU core encounter as the basis for that encounter profile. Now, what we do need to make sure of is that such use of the AU core is not overly constraining what our needs are in terms of representing that encounter, as in how much do we need to know about the basis of the request in order to fulfill and go through fulfillment of that request. Just noting that encounter is in some ways almost a linking FHIR entity that lets us then step through the chain of linked kind of clinical data. So we can go and say this request was based around this encounter, which had these other aspects of clinical information associated with it, for instance. So there is more future use potential for encounters going forward. Philip.
Yeah, and for this one, same kind of question. If I'm reading this correctly, we can say that you don't have to link it to a specific encounter, but if you do, the proposal is use AU core encounter as the linkage. Is that the right way to interpret this?
It is. And then it's just making sure that with AU core encounter, we understand the implications of AU core encounter if indeed we did think that an encounter was an appropriate point of reference for this particular request.
Okay, all right, that makes sense. I can't say for all the hospital vendors, but at least for me, we have a concept of a future order that is encounterless. And the thought process is that you would then activate that and would pick up the encounter when the patient comes back to have the test done, where you might be billing it and some of those kinds of things. But if we think to future, where the patient can take their document or their token or whatever it may be to anywhere at any point in time, there may be times, at least in my system, where it's a legitimate order or request, but I don't yet have it connected to a specific encounter because they haven't shown up at any of my facilities, at least to have the test taken, the blood drawn, whatever. And so it sounds like that would be possible here.
At the moment, yes.
Yeah, cool. Thank you.
Angus.
I'm confused now about, well, we had previous discussions about this because I need to know whether they're an inpatient, outpatient emergency. And if I don't have an encounter, how do I know that? And to Phil, what Phil just said, like if he's creating an order that's for the future and doesn't have an encounter, I would have thought that's not in scope. That's fine that you do that, but that's not something going on the wire because you're not sending the order to anyone. So once it does have an encounter, then it would have,
Yeah, so I can give you the encounter. So if I have, let me give you some practical examples. So if I have a patient and I have some blood that's going to be drawn and they're having it drawn in the emergency department, in the hospital, in the ICU, et cetera. That's an order for this visit. It has an encounter. It's stamped. Can give you all those details, right? But one of the things I'm thinking about, and when you say scope, this is where, again, the hospital kind of workflows are a little bit, well, I'm not clear yet on exactly the data information flows. And so let's take a look at, I'm in, and it could be two scenarios. One, you're being discharged, but I want you to have a repeat pathology test for this example, 2 weeks from now. Or I'm in a specialist outpatient clinic, and before your next visit, I want you to have a pathology test. Both of those are what normally we would say are future orders that are encounter lists. And the workflow in my system is if you come back to the pathology draw station at the hospital, I would have the encounter for the visit that you show up on, because that's the visit I need to process it on and charge it against and some of those kinds of things. And I'd activate the order at that point. And then it gets an encounter, and it's probably going to be, an outpatient or a lab rat only encounter kind of concept. But in the future, my understanding is that the patient may have, a token, and whether I send that somewhere or whether, the patient shows up at, one of your facilities, one of the Sonic draw stations, for example, and you request that information from me. If they haven't come to one of my facilities in my draw station, the order at that point in time where you're requesting it or where I'm potentially sending it is encounterless. And so I don't yet know inpatient, outpatient, et cetera, programmatically. Does that make sense?
Yes, you described it well, but I still struggle with that description, because I would argue that in that case, when they came to us for this future draw that you're talking about, that its encounter is still when it was requested by the doctor. He might have requested, I want you to do this now, and I want you to do 4 more over the next couple of weeks. They are all part of that encounter where he said, I want you to do this and 4 more over the next couple of weeks. It's not that. I guess it's the context of what is an encounter. The coming to the Sonic Collection Center is not the encounter of when this order was instantiated. That's a different, maybe that's a pathology encounter, but I would argue that the encounter is when a clinician decided these things need to be done under this encounter of you being in my hospital, and I want you to do these things in the future, but I made the decision in this encounter here where we made the decision to do these things. And again, I'm arguing this because I know for us, we need this patient class, and in V2 patient class was mandatory, right? So if I get an order at a path lab with no patient class, that's problematic for me now. And do I just default and say, oh, it's outpatient because I haven't been told? And maybe that's a solution. But that's kind of where I'm at.
And that's where I'm kind of thinking, right? This is the workflow that's a little bit different when we're changing how the patient can show up and the integration that's happening with this type of request, right? So if I'm the pathology draw, even if I'm not the actual pathology processor, from that perspective, I would normally need to create an encounter for when you actually show up, because that's going to be the encounter and the details I would use for Medicare claiming, associated result, all those kinds of things too. Yes, I know the encounter where the request came from, but depending on how you're using that would not be the one that I necessarily want the result to come back to from that perspective, because...
But it is the one that Medicare wants us to bill against in a public billing sense. I guess in hospitals, you're not billing in that sense. But in a pub, like in Medicare bulk billing, if we're doing multiple over many days, they are the service. It's when the service was rendered, like the original.
Correct. You're effectively creating the encounter, and if you send it back to me, then I'm getting it as a unsolicited result. Essentially, I'm not trying always to necessarily, in today's world, I'm not trying to connect it back to an order. If the patient shows up, regardless of the paper from the hospital, et cetera, whether it was intended to come to you or not. So that's kind of how it works. But if we're trying to create this kind of closed loop of the order in some of those pieces, we're going to have some of these scenarios where we can give you, I mean, like you can get the encounter that the request was created from, but the reality is that you're processing this, your results, your billing, et cetera, are going to be off of the data service.
But I think, Rick, you're confusing the pathology's encounter of doing the work from the encounter that initiated the request for this work to be done. Like,
well, remember, I'm a pathology system too, right? So
I realize,
get your
but
point,
I would make, and maybe that's where the confusion lies in your system because they're all one. But I would have thought, even I know you're both, but I would have thought there's still two different contexts when the doctor decided for it to be done, that encounter, and another encounter, which is when the pathology does it. And maybe that's where it's difficult in your system because maybe they are the same encounter. I'm not sure.
Yeah, it's a bit of a complexity. Okay, I've probably stolen enough time. Sounds like we're okay for the moment, but we probably need to.
I sort of stand that I'm left now with no patient class, which is an issue for me.
And you may have, which I'm assuming you have that issue today if a patient rocks off the street with a piece of paper and requisition, right?
I don't in a messaging sense because it's mandatory in V2, right? So you got to give me something. You're in a paper sense, someone's making a call, be it the collection nurse or someone.
Yeah. So, but you could essentially create that because in today's world, at least with all the hospitals I'm working with, they're not in the case of a discharge where it's several weeks after, or an outpatient clinic where you may go to the draw station right there at the clinics, or you may choose to go to High Street and go to your own choice, and you really only have a piece of paper. In that kind of instance, your team is making a decision around what encounter you're using today effectively because none of those orders are being messaged to you. The only time that the orders are being directly messaged to you is when it's a draw and you're providing services in the hospital, and the draw has happened from the hospital. Essentially, the patient came to the draw center in an outpatient space, or they're a true inpatient, and nurse or whoever, phlebotomist, drew it.
It's now falling on me how to make automated rules to decide what is it if I'm not told, and maybe I'm overcomplicating it. Maybe that is just if I'm not told, I assume it's an outpatient, and I present that to the on screen. And if someone wants to change that, it's just different to what we do today.
Ken.
Yeah, I mean, really, it's the request encounter. It's integral to this definition that it's the request encounter. What situation the request was encountered in, not to do with the collection. And it also applies to the reasons. The reasons applied at the time of the request, not at the time of collection. Everything here refers to the time of collection. We have to manage the subsequent collection in the tracking issues that we're going to raise in reporting pathology results. The issue, I mean, the problems that it creates for Medicare billing, that let's say you've done a repeated 6 test requests done whilst they were an inpatient, and then you've got requests in the future when they're an outpatient. That's something that HIC has to work out, because at the time of the request, the patient was an inpatient. So, that we shouldn't, just as we said before, for the reason of the request, that's something Medicare is going to have to cope with now that we've got, the finer detail. At the moment, we don't have but we can't set up a system where we're trying to predict the encounter of the collection. What we know is the encounter of the request.
So I'd agree with you there, Ken. I think my challenge is that we don't then have systems inappropriately using that encounter at the reporting time. Because take, for example, your inpatient scenario at discharge, I wanted you to have, a test or two or something like that. That order, that test, that endorsement, that follow-up may not fall back to the inpatient provider, which is the encounter that I would be providing to you in this detail, right? And that's the challenge here, is that that test may have copy to GP or other specialist or someone else that's not related to the encounter that created this order.
But again, that to me, that's all we're doing is passing the payload over from the requester. This is what the context of when I requested this was. When that is performed by a lab in the future, you're just truthfully passing over the context of when it was requested. The fact that the patient's now out in a public collection room and they're obviously not an inpatient because they're standing out in the public, and the lab then may go, oh, this is outpatient because you're out there, but it was requested as an inpatient. Like the truth fact about how was this requested? They're two things. They're not one thing to me. Like
Sure. And I'm okay as long as we're not attempting to use the same encounter necessarily as the one for the reporting side of things.
Well, I'm not sure we'll know that we're going to be doing that, but at this point, we're not trying to decide that question. We're actually just trying to decide that this is an encounter and that we're going to use a core encounter, and those details may shake out once because we don't have a constraint that says don't use a future encounter. We only have encounter in which the request was created.
No, but the premise was put is that because it's 0 to 1,
it's also how the elements defined as well. The actual definition of the service request encounter has a specific definition
under which the request was created. Yep.
Yeah.
How can a request for a service ever be created without the context of an encounter? What do requests just appear from nowhere while a patient's sitting in a home? Like there's some kind of encounter happens. This is my point.
Yes, but in the data that may not exist.
But yeah, and I'd argue that once that order has become something a filler can consume, then a counter has occurred, right? I can accept there may be like orders lying around which are future orders which may not have an encounter at some time because in my view they're kind of in draft. But from the lab sort of perspective side, once they are coming to me, there must have been an encounter that instantiated them.
So is your proposal then that the cardinality must be 1?
Yeah, that's what I'm leading to. Yes.
Can we just finish off the commentary, Michael?
Yeah, I just wanted to sort of bring that to a head too, right? So what we're saying here, this is must support. So if you have an encounter, we're going to do an obligation to say you must provide it, right? So the only thing we're trying to decide here is whether that cardinality changes to 1 to say you must have 1. I think the thing is here too, though, is we're looking at having this for ballot for comment. So this is about having something that others can comment on. This is about something we can try and test with. And whether we can do that with the 0 to 1, with the must support, saying that if you have 1, you have to provide it. And therefore, if we change the cardinality to 1, we say we cannot have a service request ever if there is no encounter. So I think we just need to put in context of that, of this is going to go to ballot for comment, when they're going to test it, we're going to play with it, see what works, what doesn't work. So we need the starting position for that. And we probably just need to bring it to a head and get a decision here.
Thanks, Michael. Kathleen.
Yeah, just my 2 cents is I feel like it does need to have an encounter absolutely supplied, because how would you have a request if you haven't had some form of interaction, whether it be inpatient, outpatient, telehealth, it doesn't really matter what it is, there has to have been some sort of encounter to initiated it. Even if it is orders going forward over time, there's still an encounter that initiates it.
Thank you. Daniel.
Yeah, just quickly, and I think this may be out of scope of what we're trying to do, but certainly in the case of a public health scenario like COVID PCR testing, you are definitely going to have people coming in without an encounter. Whether that fits within our e-requesting concept, and if it doesn't, please just say no and I'll back off.
Can you describe that COVID scenario? So how does a COVID request get created without an encounter?
So I had to do a lot of PCR tests because I was traveling during COVID. Arriving in Melbourne, I had to get two that I had to rock up at a test station to get done before I was allowed to be out in the public. So there was a lot of that kind of stuff going on. Still some background COVID stuff that takes place at the moment, which is not initiated by a clinician directly.
I still don't understand how there's no encounter. How does someone arrive to have a test done without there being some interaction, even if that interaction is that point? Like
so
there has to be something before the lab puts it on an analyzer. There had to have been an encounter.
So scenario, have to get a PCR test to be able to fly. Within 24 hours, 48 hours of flying, there was huge queues of people rocking up at the test center to do that. There's no paper form that you have. You fill it out when you get there.
So right there, when you filled it out, is the encounter.
Can I just check the logic here? We don't have a request in this case. Why do we care?
Yeah, well, that's what I was saying, and it could be out of scope. So please forgive me for raising. I just was trying to think of edge cases that we needed to cover.
I think you do. I think you do have a request.
Public health emergencies are significant.
You still have a billing context of that collection encounter. So that is the encounter. So it's effectively a request created by the patient arriving. So yeah.
And that's different to the earlier scenario where you've scheduled ones in the future. Like they were scheduled and have on the encounter when they were scheduled. When you arrived is a different thing. So when there's this scenario where you arrive like a COVID test and there's been supposedly no request and you've arrived, then the encounter is literally when you arrive, and that's independent to the millisecond later of the pathology episode being created.
Yeah. And there's still a valid authorization, which is the service request, and has a context of that authorization. Because there's a clinician and an encounter to be able to authorize that.
And even if there wasn't, even if you're rolling up directly to a lab like a COVID drive-through or something, and where we're just going to do the test because the government said we can, in a data sense, there's still like the step of a request is created as I stand at your door, like, and it might be the lab creating that, but that's independent. It's still there, right? It's still the encounter of me leaning in your door and sticking a swab in your mouth.
It's the basis of Sonic getting paid, right?
So, it is the basis of getting paid. Yeah.
So there will be
now we come to the other.
That's why I'm arguing so hard.
I'm going to get to Ken soon. Kathleen.
My apologies, I didn't lower my hand.
Oh, Sanjeev.
I think we had discussed this last week. I understand where you're coming from, Angus. And again, I'm just talking about our system. It allows a request to be made without an encounter. And my concern is, I know you're right, absolutely right with what you're saying. We're trying to enforce changes via integration, whereas the scope for our one should be to implement what we have. By enforcing cardinality to one, we'll be enforcing changes in products.
So does your product create
workflows?
Do you create a V2 order today, Sanjeev, in your system to send to anyone?
No, we don't create. But I'm just saying, even if it's a manual order, it's like an INR request. It is possible to create it without an encounter.
So you're describing a system that doesn't create electronic orders, and then saying we're impinging requirements on that system that doesn't actually do electronic
I'm
orders?
saying, I'm not telling you about system, I'm telling you about the clinical workflows. Clinicians right now are creating requests without an encounter, and then you'll be enforcing this via integration on them. That's my point only. Whether right or wrong, I'm not questioning that.
Yeah.
Ken.
There's another scenario that exists at the moment, which is there are internet providers where a patient just goes to a website and generates a request on behalf of a doctor that they've never seen. Strangely enough, Medicare approves that request because there's a provider number associated with that request. They've saved on a consultation, maybe. But I do agree with Angus, that still is an encounter.
It's a website interaction.
Yeah, it's a website interaction. And whether it's a form that's not signed by a doctor or an electronic order that's not in the presence of a doctor, a presence of a nurse or whatever it is, it's still an encounter that generated an electronic request. You have to sort of try to separate it from the idea of a medical encounter, like an inpatient or outpatient consult. There was still some scenario which generated an electronic request. They can't appear, and that might be separate to a clinician request. It may be triggered by a patient turning up if Medicare allow COVID requests to be billed and sent by a patient just turning up to a centre. But I agree that it's just a new definition of what a type of an encounter it is, but it's still an instance that generated the request.
Adrian.
Yeah, I'll just some notes into the chat, but I think from what I know of this, we use encounter for a hospital service request, for example, in FHR terminology, but for privates, it's not the information is not relayed. So same situation that I mean, 0 to 1 is probably our current paradigm. You don't need an encounter to have an order. Yep.
Thanks, Adrian.
That's all. Yeah.
Brett. I might actually conclude after you, Brett, because I think I'm just going to go. I'm going to draw a line in the sand.
Thanks, Eddie. Yeah, so I was just going to back up what Ken and Angus were saying about types of encounter. I mean, you have a patient, a clinician, and a venue, which may be electronic or actual physical or on the phone or any of those types of encounter, right? And encounter sort of covers that as being a possibility. And I think primarily so far, the need is really around the class of that encounter, being needed to service the request. And so I think whilst getting caught up whether encounters are recorded fully in systems is something to think about, I certainly think based on the context of the clinician making this request, you are probably able to populate the class of the encounter in terms of whether it's inpatient, outpatient, or some variation thereof, right? To be able to supply that information. So I think we still need to explore exactly what's needed for eRequesting, in terms of actual requirement, because there's a lot more detail in an encounter that could be provided, but I don't think we're necessarily asking for all of that in this context. So I think basically we say we really think we need it for that class information, but I think we need to explore that further. So this is a good way to kind of get to that.
Okay. I thought that's where the discussion was actually going to go, is what is actually in an encounter. But we seem to have, because there's a bunch of must supports in encounter, and they then have implications here as well. Having heard all that, if there had been no commentary that argued that it wasn't absolutely mandatory, I'd kind of tend to go with you, well, let's change the cardinality. I'd make, I guess, a friendly amendment to the current proposal that's on this page to say, would people be comfortable with adding must support onto this? I think this goes back to what Michael originally said. we made it must support, then it meets the obligation. If the argument is there is always an encounter, then it's always going to be there because it's must support. I think, given we've just spent, well, a fair amount of time discussing something that if it was blindingly obvious to everyone, we kind of would have shortcutted it, I would have thought. So I think making a move to absolutely mandatory is it's one of the extremes of kind of the supporting. So I would like to propose that we amend this to make it must support, which means that if the request is made in the context of an encounter, you need to include an encounter.
Yeah, I just argue like Sanjeev's example where he says my system doesn't do this. So he's going to say I don't have one that's must support. I can't provide it. Where I'm of the view that what they're really doing is they're just defaulting sort of they kind of have a default where it's not clearly a hospital inpatient or clearly an emergency or something. They then just use the default of it's kind of an outpatient thing there is no encounter. And I'd argue there still is. He might just think the default is there's nothing. Yes, and and even if he doesn't want to store it in his system, when he creates an order to send to a lab, he has to go, it's an encounter outpatient. So I'm still going to vote negative because must support's not going to give me an encounter from Sanjeev's system.
Yes, and do remember that you still conform it with the profile if you make it mandatory. In a taking this profile and making it more rigid, it doesn't work the other way around. If we make it mandatory and you try to make it optional, that's not going to work either.
Can we?
I was just
did you
going to
make
go
a
for
motion,
vote.
or did you? Yeah. Do you want to make a motion then?
Yeah. So my motion is that we take the text as it appears as the approach and add in must support to it as a compromise. Does anyone second it?
I'll second.
I second Michael Osborne.
We have 2 seconds and a third.
So we're going to go to a vote. If you support service request encounter 0 to 1 with must support, in the affirmative, you vote yes. If you disagree, vote negative. If you do not wish to vote, then you may abstain. Okay, so we've currently reached 79%, 81%, so I'm going to close the voting. We still don't have a clear majority here, so if anyone else would like to vote, please continue.
Adrian, is your hand still up for a question?
No. Thanks.
Okay, we have 89% participated. Does anyone else wish to vote? Closing the voting in 3, 2, 1. So the results are less conclusive. We have 45% affirmative, 15% negative, and 40% abstained.
No, that's definitely a majority.
Yeah.
In terms of that, when you take into account abstain is not counted. It's affirmative against negative.
Okay, I'm gonna go with your expertise there, Danielle. So that's affirmative 24 to -8, and that one is passed.
And just remember, this is not the end of the discussion. This is only positioning for the ballot for comment, and I'm expecting there'll be a lot of commentary around this coming through in the ballot for comment. In fact, this means you have to read the ballot for comment if this is an important issue to you.
Chris, can you just give me the number of abstentions as well, please?
Abstentions 21, abstained.
Thank you.
All right.
I knew 13 was a bad number. Service request code.
Andy, just sorry on this one. There was a meeting on this yesterday with some of the co-chairs that weren't there. Michael Osborne was going to present a proposal on this, which is actually the next slide.
Yeah, thanks, Andy. I'm happy for you to drive here. So this was a bit controversial because we didn't have much meat in this last time, but hopefully we've met with Ranska and RCPA, and we've come to some conclusions around what our approach should be for this binding. So for radiology requesting, Cyro's been working with Ranska to produce quality codes for this. So we're talking about a single code. If we just jump forward a slide quickly, I'll give you a flavor of what that is. Onto 16. So these have come from Stuart at Ranska. So essentially we're talking about a pre-coordinated term covering all angles, so left, right, bilateral, with, without contrast, this kind of thing. So just jump back again to 15. So if it's not in that set, we would accept a procedure code from SNOMED CT, so an imaging procedure code. If it's not in SNOMED CT, we would accept a local code from your system. And then if no local code, we'd happy with free text, but also saying that we really need the free text because that captures what the clinician selected and what was most closely represents the intended meaning of that code. And similarly for pathology, if you just jump forward to 17, so some examples of what's already in the RCPA SPEAR set, and we're working towards making that a fairly complete set as well. They're just jumping back to slide 15. So if it's not in that SPEAR pathology set, we prefer a laboratory procedure code from SNOMED CT. If it's not in that, we prefer a local code from your ordering system. And once again, a free text test name, and that'll be mandatory. So what the motion is that the Spark team will work with the colleges towards a standardized way to capture radiology and pathology tests to a very high standard for exchange. So we're only talking about exchange here. We're not talking about what your system might do to get to that single code. So for example, if your system has 4 boxes for ordering radiology, where they put a modality, body site, laterality, and contrast, we'll be working towards giving you methods to getting to that single code, that single pre-coordinated code, and that will require supplements such as value sets and concept maps to get there.
Sorry,
so our
Chris,
proposal is
that slide
essentially
isn't
our
the
proposal
proposal.
is this. That slide, yeah, the slide after it is our proposal. So in the IG, we will make this concrete essentially. And do I get to motion that, or does anybody need more explanation? Philip?
Yeah, one quick question there. So my understanding is that the various value sets that you're proposing here have primarily been looking at the GP community ordering and not necessarily mapping to all the orders that would be available to providers in hospitals, which are often only done in hospitals. I get that. Do we have a strategy to, your proposal would allow for that flexibility. So happy to, in my mind, vote for this as a positive. But my question is do we have a strategy to eventually cover those additional tests that
right, I'm going to throw out to our partners here.
Yeah.
So I'm going to throw out to Stuart and to say David to answer that one.
Thanks for that. So what Michael just showed was a small percentage and just one of the procedures. The radiology referral set as a whole will attempt to encapsulate every single possible radiology procedure. So that includes interventional, nuclear medicine, fluoroscopic, and then also some of those weird and wonderful tests that we get inside the hospital. So currently we have a forecast of something like 4,500, 4,600 total SNOMED codes to encapsulate the radiology procedures. And then we'll send that back to our clinicians for gap analysis and validating as well. So we will cover as many radiology procedures as physically possible.
Thank you.
David, did you want to talk to this?
Which David?
David Willits.
Sorry, I was thinking the same thing, Michael. I wasn't sure whether you were talking to me or not. No, that's exactly what we agreed yesterday. So we'll take the pathology request and value set for testing and go from there.
Yeah, cool. Next question is Brett.
Just specifically in the proposal, what is it? We're proposing a binding, a direct binding as per that statement. Is it an extensible binding to those value sets?
I think it's more than that looking at it, because that was the original slide. And
Yeah, that slide's not valid, that 14 slide.
But there has to be a primary binding to something.
And I think looking back at slide 15, I think and I'm interested to see if people are happy with the proposal that this is, I guess, the order of preference in terms of concepts.
So do we state there's no binding?
No, that's not what I was saying. I'm interested about this, and then how we put that in the implementation guide. I would suggest that there is indeed where we go might be preference.
Yeah, because that's my question. So is there actually a preferred binding, which is the two sets in context?
Yes, I think
is that preferred or is that extensible? Because that makes a big difference to implementers.
Yeah, and I just realised I've leapt over people, so I'll let them talk first, and then I'll join the conversation around strengths and that kind of thing.
Yeah, so it's just clarity on the actual binding to the element, and that might be context specific. So whether it's radiology or imaging, because if it's extensible, that means you are required to use a term from that set unless it doesn't exist. Then you have other options.
Based on what I heard from Michael Osborne's description, I would think that would be extensible.
Yeah, I just want to make sure that that's what we're voting on, if that's what people understand.
I don't think that's true, but is it because aren't we allowing people to effectively not use SPIA? Like so yes, the code's in SPIA, but for whatever reason they aren't able to use SPIA and they're using one of their local codes.
No, that's not what extensible says. Extensible says if it's in there, you have to use it.
That's what I mean.
Concept
but I mean, so it's not what we're at least what I think we're proposing is not extensible. It's preferred, isn't it? We prefer that you use RCPA, but if you can't for whatever reason, you can use your local code for full blood count.
Yeah, I just need that clarified in the proposal because that's what will get implemented. So the difference is that you'll get a warning if you don't use a term from that directly bound set, but that's all you'll ever get is a warning.
So based on the discussion yesterday and this slide, current proposal is preferred. If anybody wants to propose otherwise, then they should do so. But otherwise, we'll go with preferred, I think.
Lots of hands up.
Who's taking the lead for this? The chair? Want to take the questions?
Well, I thought you were playing the game,
Okay.
Michael. So
Ken's got his hand up first. Let's go with Ken.
It's difficult to know how the radiology have incorporated body site and laterality into the single request code. Now, the short-sighted opinion is that full blood doesn't need body site or laterality, but all biopsies do. So this requirement requires that all biopsies also have body site and laterality. So it's going to create a lot of work for the College of Pathologists to define all biopsies by body site and laterality. So that's almost an infinite scope of what descriptions will be required in the single code for a biopsy.
I've been thinking about that one, Ken.
Alternately, you have to
go
use
ahead.
the request description, and we haven't really defined that. And we don't really want body site and laterality in amongst all the associated notes for the request. So I just think that the whole issue of losing where the biopsy came from is a risk here.
I just like to answer that one, Ken, and that in your pathology system, how many different panels have you got for biopsy? You probably only got one. You probably got one test for histopathology.
Exactly.
So we're not recommending that you go and code every single body site biopsy. What you'll find is there's one code for histopathology in that set. You will use that, and there's other fields in the service request where we can put specimen, because you're going to get a specimen with that biopsy potentially. So there's a specimen resource. You can get the person to fill that specimen resource out and send that in.
So that'll have
I would not expect anybody to create multiple biopsy request codes.
So the specimen resource will have to code all of the different body sites and laterality.
But we've had that discussion too, and didn't we get to the conclusion that specimen resource is out of scope because it's part of collection? Just to throw a stick in the wheels.
Well, I think it's necessary if you're going to get a request with, like, for a biopsy or something like that, or cytology, whichever one of those is. But next question, I think, was Andy. Did you have your hand up for a question?
Yes, I did, sir. I think the overlay of the preferred term in this hierarchy, I'm interested to see how that overlays into an IG in terms of its in the specification. I think I'm completely in agreement with the intent. It's just not clear to me whether the intent will match the specification. So I'm very interested in how that could occur. And I guess just around the local code, I would like to see that local code actually bound to a local code system. And so I guess maybe we expect that, but it would make sense if where there is a code that it's preferable that code system is actually exposed, so that you can validate these codes that you get that happen to be locally created, and also allow you to build potentially concept maps if that's an appropriate building block to allow greater interoperability of these local code systems. And obviously through this, we actually want over time that the coding needs propagate up. So where there is use of another SNOMED term that's not in, say, the RANSCAR, well, no, let's say that the RCPA choosing SNOMED, if there's a SNOMED term that's not in there, then the likelihood it's going to get in there if it's an appropriate coding to use. Likewise, with local codes, you would expect over time that hopefully there's some agreement and there's propagation of those local code uses into SNOMED or SPEAR.
Andy, can I just jump in to address the first question there? I think how this gets implemented in the IG was something we wanted to not cover right now. I think we wanted to get the intent out of that slide 15 as, do we all agree on that's the intent? And then I think it is essentially for the IG developers to go away and formulate how we implement this in the IG to fulfill this intent. But it was probably too much technical detail to get into with this. Just we wanted the TDG to try and agree on this intent as the proposal to start with.
Yep, and as stated, I agree with the intent of this in terms of the hierarchy of options.
So I'm going to jump in here. We have 10 minutes to go for today. If you have a really critical comment on this, please leave your hand up. If not, we should move towards a vote within the next 3 to 4 minutes, please.
Would you like me to restate the proposal?
Yes, I think that would be useful.
Okay, so the proposal is that the Spark team and the colleges work towards a standardized way to capture radiology and pathology tests to a high standard for exchange. And the proposal is that when there's not a college acceptable code available, there's a fallback approach. The fallback approach is to use SNOMED CT procedures as per this slide, or local codes over free text. And if there is free text, it's mandatory to have, well, it's mandatory to have free text. And that the IG publishers will go away and make this available in the service request artifact for comment. I'm going to motion that. Do I have a seconder?
Can I make a friendly amendment, please?
Sure.
Because we have to clearly state we prefer the use of the value sets, not we will use the value sets, because it's two different things. Yeah.
Okay, with that amendment,
yep.
I move this with that amendment. And I had Stuart as a seconder.
Yeah, I'll still second.
Let's go to a vote.
While people are voting, just to reiterate Michael Wilson's comment that this is very much an intention and there'll be opportunities to test this process. Obviously there will be later time for actual proper vote for the approach, but this is, I guess, an intention so that we can progress and proceed around the testing approach.
Ken, your hand stayed up. Did you have a comment? No.
All right, so we are at 77%. Anyone else would like to vote, please do so now. I'll close the voting very shortly. 3, 2, 1. All right, and that one is passed. 39 for, 1 negative, 3 abstained. Thank you very much. What is next on our list? Do we have time to do another one, or we've got body site? Do you want to talk about it briefly, or shall we cut it off here?
Not that one.
Given we're not, I don't think we're going to complete necessarily another one, given what the one after this is. We're going to have this discussion anyway. So I imagine, given what Ken said, that it's probably worthwhile, given that previous coding approach, that we, I guess, expose the, there is a body site within the service request. We've put that in as optional. There's clearly a potential issue here where the body site that is included within the code contradicts with the service request body side, or you know, there is no body side, but there is one in the code, and vice versa. So those combinations are something that we need to be comfortable with. At the moment, we have attempted to be as, I guess, unimposing as possible and allowing for all options. So I think we should have some commentary, because otherwise I will bulldoze ahead and simply, given I don't think this is constraining, so bulldozing ahead I don't think would be necessarily lead to a negative outcome, given where we are today. And obviously we are going to for commentary anyway, so again, that's not a critical issue. But is there any commentary around the overloading and the use of body site with respect to the discussion we've just had? Brett.
Yeah, just to say, I think just from what Ken said, I think we're going to need to have it in use. So I think we should. I think what's stated here makes sense, because it's you use it when you need to, and there's a reasonable binding that is preferred. So I think it makes sense what's written here. So I would say we kind of need to have it, and especially with the development of the value sets going on, where I'm pretty sure we will need it.
Okay. Now, Chris, you yell out when you want to pull us to a halt, because otherwise I think we'll go on for about another hour.
Well, we have 3 minutes.
Yeah, I want to briefly talk about something actors for next meeting as well.
Okay. Well, we're going to have to, we'll cover this next time, because it's clearly not going to be concluded today. So go ahead, Mike.
Very good.
Yes, so according to our sort of schedule, we were going to finish the wave 2 today. So we've obviously got a couple of hangovers there that we'll have to carry over. But the next meeting is about system actors. So we've put together a Confluence page. I'll just put it in the chat for everyone. So this is to socialize some ideas around actors. I may just share my window. Probably don't have time, but that's all right. But if you follow the link, they'll put in the chat. There's a Confluence page with some initial thoughts about system actors. So we're going to go through this next Tuesday. Please have a look at this, add comments at the bottom so that we can go through that in the next meeting. So feel free to add any comments in there so we can get to a conclusion, because we really need to get to a conclusion on system actors in next meeting. So we won't really have a chance to come back. So come in prepared with your thoughts on the actors.
I think too, I prepped some slides for that discussion as well, just in terms of framing some of the language and stuff we're talking about as well. So hopefully that we'll be able to cover that.
And the system actors are important for the obligations. So when we get to obligations in wave 4 there, we say what obligations fall on what system actors. What do these system actors have to do? And what obligations do they have? So that's why it's important we get those actors right, because then all the obligations refer to those system actors. So it's an important one we get right in the next meeting.
All right, and for those of you who aren't reading the numbers up the top of that screen, the next meeting is next Tuesday. So we look forward to seeing you all there. Thank you very much for today. We did make some good progress, and we should be able to wrap this up nice and quick, I hope, next week. All right, thanks everyone.
Well done.
Thank you, Jake.
Thank you.